you're interrupting you're interrupting the natural detoxification of the sleep, which is very important, because if you have interrupted sleep, then you compromise the immune system, then you put your risk of having cancer. And we know the
Dr.
risk.
Halasa,
Yes.
sorry, just wanted to add something. I did come across some literature talking about progesterone, actually, men using progesterone as well, and that may also help with shrinking the prostate gland, because if you think about it, it's like estradiol estrogens, I guess you could say, are causing proliferation or overproliferation in the women if they have low progesterone, like the fibrocystic breast disease or uterine fibroids. And so the progesterone needs to be balanced out with the estrone to inhibit that overgrowth. And I gathered from, I'll have to find the the literature that I found this in, but it makes sense. So if estrogens are causing overgrowth of the prostate gland, then perhaps we need progesterone as well. We have to decrease the estrogens, the estrogen dominance, but perhaps add progesterone to balance out the overgrowth, to inhibit the overgrowth.
Right. So with that, we do for the female, especially, and we can do it for male. Progesterone in male will be converting to testosterone, by the way. And then the testosterones, and then progesterone also, yes, it will help to, what it does, estrogens, it stimulates the proliferation, progesterone stimulate differentiation. So that's exactly what you need. If you want to counter effect the proliferative effect of estrogens, that's already being converted from the testosterone, then adding some of progesterone will be good for the male as well. So I believe in that too. If we add some progesterone in the formula, then I think we can get the ultimate better result, which is balancing those six hormones. But we know the culprit now. It's the estrogens, and it's very critical that we inhibit the aromatase. And adding progesterone is, I think, it's a good idea. We do that for estrogen dominant syndrome in female as well. We give them progesterone to balance the proliferative effect of estrogens with, or estrogen with the differentiation effect of progesterone. Well, testosterone does differentiation, by the way, but the estrogen causes the proliferation, and so we can boost the testosterone to stimulate the differentiation. We can also give them. Eventually, progesterone is the mother of both sex hormones, male and female. All the progesterone eventually will be convert into testosterone, and then testosterone will convert into estrogen, right? That's even from female. The ovary job of the ovary is converting the testosterone that's produced by the ovary into estradiol. And the aromatase of activities of the female gonads is way higher than in the male testis. So that's the reason we produce more testosterone than estradiol by the gonads of male. Why we produce more of estradiol than testosterone, because aromatase of the female is whatever active. But very important to know that aromatase enzyme of the gonads does not inhibited by the aromatase inhibitors that we are giving. So there are two isomers of aromatase enzymes. Gonadal aromatase are not the similar as the one in the adipose tissue. And so if you say, oh, well, you're giving aromatase inhibitors, is this aromatase inhibitors inhibits the gonadal aromatase, which is very critical to keep that intact, especially in female. Think about it. It will be a problem, right? So the DEM and calcium glucarate and iodine and anastrozole does not inhibit the aromatase enzyme of the gonads. And you don't want to inhibit the gonadal aromatase. You want to inhibit the fat aromatase enzyme. And so Dr. Mike Emanuel is a compounding pharmacy, designated compounding pharmacy of this group. I urge him with his assistant, Renee, to start developing aromatase inhibitor for all the patients. And if you want to add progesterone to it, Dr. Joseph is suggesting adding progesterone. That would be fine. But that can be added in the testosterone cream, in the cream of testosterone. When you're giving the patient testosterone, progesterone, then you can add progesterone to testosterone cream, and then give just the capsule of this aromatase inhibitor to everybody. Everybody, we need to save and decrease the percentage of the prostatic hypertrophy and prostatic cancer. It is unmet medical need. It's been debated for a long period of time. Today, we clear the understanding of how we can give testosterone to patient with low testosterone and does have prostatic hypertrophy or symptoms of prostatic. And you don't want to aggravate the prostatic hypertrophy, then you need to give the patient aromatase inhibitor, which is the thing, the ingredients that we suggested is anastrozole, calcium glucarate, and DIM. And I hope Mike Emmanuel will have it available. And everybody above age of 40 or 50 has to be on it. Because if we're able to reduce, let's say, if we're able to reduce the percentage of finding cancer, prostatic cancer, of the age of 80 from 80% to 60%, that's success. If we're able to reduce the chance of having prostatic hypertrophy from 50% of the 50 years old patients into 30% or 20%, that's a great success. And we need to come up with some studies and see if this is the case. And I think this will help to decrease the problem of prostatic cancer, which I think I think the second cause of death in male. And we need to answer that debate and challenge it between mainstream medicine, who are down looking at the integrative doctors, who criticizing them negatively, of course, by recommending testosterone cream for patient with prostatic hypertrophy. I think it's very critical, this this solution. If you have any questions, because we're going to move on to another topic, which is the topic. All the integrative doctors, they like it. Most of integrative doctors, almost 50% of their patients and 50% of their management protocol is directed to chronic inflammatory response syndrome. I think Ziti Berger here, Dr. Ziti. Syndrome, because she called me and say, make sure you pronounce syndrome, not syndrome. So syndrome, okay? Chronic inflammatory response syndrome. That is what we're going to talk about tonight. But before we move to that topic, I want to make sure that everybody here is in touch with Dr. Mike Emmanuel, and with his assistant Renee, and everybody here. I want you to start recommending your patients and for yourself this combination of just 0.1 milligram of anastrozole, not one, because we know that anastrozole have side effects of mass, muscle, and bone. So we need 0.1. And then we need those three supplements, 10 milligram of potassium iodine, DEM, and glucarate. I think I did send all the milligrams and all that to Dr. Mike Emmanuel. Are you there, Dr. Mike Emmanuel? Can you make this available for our group?
Yes, I'm working on it. It's going to be ready very soon.
Okay, so not just, even Dr. William, he told me, hey, I need this for me, for myself. So I text the phone number of Dr. Emmanuel.
Yeah, we got supplied by a few days, and it's going to start.
I need it for myself too, because I'm at the age of 50 and I don't want to die with prostate cancer. It's a very nasty disease, and both of my grandfather did have prostate cancer. Yes. One of my grandfather, they used the old method, which is removing their testes, orchidectomy, and he survived maybe 10 years after that. But if we start from now, prescribing for all the patients aromatase inhibitors, and if you have problem with anastrozole, just start with anastrozole for 3 months, with this supplement. And if you see the estrone and testosterone is being regulated and there is no symptoms of the prostate and everything is fine, then you say, hey, I will take off the anastrozole and just keep the supplement, the 3 supplement we talked about. And that would be good as well. If you are, kind of integrative doctors does not want to have big pharma to their patients. But it's starting with 3 months, 6 months of anastrozole, 0.1 milligram daily, and it will be a good idea. And then you switch them to the supplement only. Any questions regarding this? Is everybody here agree on this new approach and this solution or understanding or the new understanding of testosterone and prostatic hypertrophy and prostatic cancer risk, and how we are kind of solving the debate between these two aisle, mainstream medicine integrative doctors? So if there's any mainstream doctor here is objecting, come up to the mic and say, yeah, you're wrong. Or integrative doctors who have any questions or concerns, just go ahead and please ask the questions. Is anybody here? All of we agree?
Yeah, it makes it.
Yeah. Well, all right, let's do.
Oh, hi, Dr. Halasa. Sylvan. Hi, how you doing? I have a question. I think anastrozole 1 milligram per day, 7 days a week, is a high dose for a man.
No, I said 0.1.
Oh, okay. I'm sorry. I misheard.
No. I don't want to give 1 milligram. That's too much.
I misheard. I'm sorry.
0.1 milligram, and we can go ahead for 3 months, 6 months in our
Right.
formula. And then if they say, hey, somebody's, there's a background voice, right? Okay. And then if they say, we want to switch to only supplement, then, the compounding pharmacy or Dr. Hotan, he's doing the supplement. We can mass produce the supplement. We cannot mass produce big pharma product like anastrozole. So you can go 3 months, 6 months, and then you can switch them to the natural only. But how you monitor that? You monitor it by measuring estrogens, not any estrogen, estrogens and the testosterone ratio. And we're going to have a discussion on exact ratio and things like that. So anybody have any questions? Are all of you are happy, cleared about this?
Yeah, no, it looks good. Really quick. So this is not the weight loss capsule. This is separate, right?
Yes, because some people who are already, their weight is okay and maybe underweight, and we need to have a solution and more aggressive solution for low testosterone and prostate. So we need to add more of a stronger aromatase inhibitors. So, but if somebody has weight and still they have prostatic hypertrophy, I think we need to give them a capsule plus, which has some DEM there, but we need to have higher DEM concentration, higher glucarate, and anastrozole. So this is more potent aromatase inhibitor.
That makes sense. And just a little feedback on the diet pill. Some people are having issues with flatulence from it still. So I don't know if there's a way if reducing the acarbose is maybe a good idea.
So they have problem with the carbos because of the gas?
Still, yeah, even though you have the activated charcoal in it.
Okay. Yeah, so that's the point where we can add the acarbose. We can add more gas tablet or capsules, because you want that acarbose. That's mean it working. If there's gas, that's because of you inhibiting the absorption of carbohydrates that the patient is eating, and it's being fermented by the bacteria to the gas. Okay. So either you lower the acarbose or you add another anti-gas supplement to manage that. If the patient is looking for dramatic decrease in weight loss, then it's better for them to add anti-gas supplement. Now, the anti-gas is activated charcoal, and there's another one. What is another one that you add, Doctor? There's 2 kinds of them. If you can...
Albino and simethicone also.
Yeah, can you add both in those patients who are having more gas?
We give it to them separately because the capsule cannot hold all of them together.
Okay, do you think, Dr. Joseph, is that better solution to add anti-gas? Because having gas, it's good. That's mean your
Yeah, but the
cabbage is
problem
doing.
is the problem is that there's a lot of patients who, especially, well, I have a lot of female patients in their 30s that are going to not want to take it just for that reason. They're, even though it makes sense and all the logic is there, I don't want people to get turned off just because of, unpleasant side effects. You know what I mean? So maybe it's just, maybe there's a way we can tweak it, or, a little bit, just to
You can
reduce
lower
that.
the dose of acarbose if we work that with Dr. Mike Emanuel and increase the dose of the anti-gas. But indication of there's gas, that's mean there is no other option in terms of safest way to decrease weight loss. If they want to reduce the gas, they stop eating too much of carbohydrates because that indicates they're eating carbohydrates and acarbose is preventing it from absorbing. But what we can do, eventually it will be fermented by bacteria, turn the gas. And we're going to stop that by inhibiting the gas production. What is the other solution you think that
No, I like that. I mean, that's part of the patient education, is to say, yeah, well, if you're having flatulence, then that's a sign that you're eating too many carbs. And I mean,
right?
it's a sign that it's working. But part of the program and weight loss is to reduce carbs.
Exactly. Okay, so what is there is no other solutions for, and then acarbose does not work inside the body. It works in the GI. So that's the most safest thing you can give to the patient. If things it's working in the GI channel, in the GI, and it's not in systemic. So we don't have any side systemic effect of acarbose. Like metformin works inside the body by increasing insulin sensitivity and inhibit the appetite. But acarbose does not go in, so you don't have any systemic. And acarbose is a byproduct of bacteria. It's made from bacteria, same like ivermectin is made from bacteria. Acarbose is also a drug that's made by bacteria. It is the safest way. So if they have too much of gas, you tell them, hey, that's because you're eating carbohydrates, and
Maybe you
maybe
can
that will help
recommend
them.
them to take Beano also along with the diet
And then
cap.
just add the anti-gas supplement. Say, okay, if that's the case, because you want, that's the only solution I can see. What you can do better than this? There is none.
No,
And if
no,
there's that, yeah,
makes sense.
right. But they have
It
to take
does.
it at night. A lot of those anti-gas, because most of the interaction between their partners happen at night. So yes, you want to make sure that they are loaded with anti-gas, and anti-gas here, it's for the gas and also for those activated charcoal. It's also for detoxing the body along with zeolite. We developed a cocktail of supplements. I think Mike Emanuel has it. And what is the program here is in the morning, they take Dr. Hutanis, which has the probiotic, the Bediform Bactrum in the morning, and it has other polyphenols in that capsule in the morning. And then before meal, 30 minutes before meal, they take the acarbose and metformin. It's a very low dose. All of them are the lowest anti-diabetic dose, but it's more safer than Ozempic, because Ozempic, there's a lot of problems with it, systemically and health-wise. I mean, patients, they end up with cachexia, and sometimes it's hard for them to even reverse back. And they have bone loss, muscle waste, plus they have risk of having pancreatitis, and they end up with full-blown diabetic mellitus. Think about it. But we need to come up with some genetic testing for Ozempic to make sure those patients with susceptibility of pancreatitis and massive cachexia, that they will not be taking Ozempic, or using lower dose of Ozempic and then complementing it with the alternative capsule that we developed. Again, if you want to have solution for weight loss, this is the safest way that is not systemically, most of those things, and it's more friendly. But again, there's a problem with the gas, and we mentioned and we noticed that from the beginning, and just ask them to double or triple the dose of the anti-gas. And maybe if they're got there to their weight that they need, then they just continue with the supplements, and detoxing at night, and the probiotic in morning, and maybe we can remove acarbose, or lower it, and just keep the 100 milligram of metformin and amloxanox and naltrexone and all the good stuff that we add in the capsule. Any other questions? Are we good with this new capsules for all the men of 50 and above, to start with aromatase inhibitor supplements? It's only one big pharma ingredients that we put, which is anastrozole, which is 0.1 milligram, not the pharmaceutical dose. Anybody has questions? Are you all happy with? Is that me? We agree? Because the whole purpose of this platform is to verify the information that we are learning, and I can. I think we have 23 doctors here signing in this, verifying and reviewing this information as correct, and there is nobody is raising his hand and challenging it. We need those people who may have other opinions, or other approach, so we can learn from them. Okay, let's go ahead to. So as you know that I'm writing a book of chronic disease prevention and management. Can you see the screen?
Yes.
Okay, so you see the book, right? So I finished up to 500 pages, and something happened to one of my files of the book where I lost the last 200 pages. So what I need to do is that when I'm putting this bulk, because it's writing a book is like sculpture. So what you do, that's what Mr. Schill is saying. What you do, you start adding information, of the book, like a bulk of information, right? And then after that, you have to go through it, review it, and start sculpturing it. And then you give it to the doctors, which Dr. Schill is going to do, because he's the coordinator of all the editors. And he's going to distribute the chapters to the doctors who are interested to be editors, and add their perspective, add their vision, add their blueprint, add their touch. And so that will be coordinated by Dr. Schill. Now, the chronic disease prevention and management book that I am writing is revisiting, revising all the medical knowledge that we have in managing chronic disease across all medical specialties. Any chronic disease affecting any organ of your body, any systemic, any chronic disease of any specialty, whether it's neurology or cardiology or ophthalmology, or all those chronic diseases of all these different medical specialties, we're going to revisit their management and combine what is known and what's FDA approved, the conventional protocol, with the alternative complementary integrative protocols. Coming up with that combination of these two protocols, and we manage them based on those 4 pillars that we talked about. The blueprint of chronic disease prevention management is the redox, immune, metabolic, and regenerative. Before I start with the, I am not seeing the screen anymore. And so I recommend people who I gave them the co-host, and I'm going to give more co-host to everybody, to add people as they coming in. So Dr. Joseph James, can you help me with that? John, all of you are Dr. Mike Emmanuel, Shellstein, please help me with adding people. And not just that, I'm giving you the co-host for all of you almost, so that you will consider this room as your room. And so please invite all your contacts, all your people, uh, invite them to attend and contribute with us in redefining medicine and coming up with all these trends. And forget me if I miss anybody in the co-hosting, because we need to go back to the lecture. Um, and yes, so let's start with this new title. Almost 50% of integrative doctors, they are managing patients. But what is their management? 50% of their management is directed to chronic inflammatory response syndrome, right? Uh, most of the integrative doctors do work on this condition. It's a new terminology. It's a complex condition that occur when the body immune system overreact to the stressors. And those stressors are the biotoxins. And I think Dr. Joseph did talk about biotoxins. He has a lecture that we learned from him about the biotoxins. And biotoxins are spike protein of the COVID. Biotoxins are the fungus myotoxins. The biotoxins are the bacteria, uh, lipopolysaccharides and bacteria, the toxins. And so those biotoxins are mold exposure or biotoxin infections, which are the bacteria infections, viral infection like spike protein. And our immune system respond to those biotoxin with overreactive immunity, unnecessary, unwanted. Which immunity, which part of the immune system that's being overactive in most of the biotoxins is the Th17. This is the culprit of not, Th17 is more than Th1. Some of them they have overactive Th1, some of them they have overactive Th2, but all of them, all the immune reactions of the biotoxins against the biotoxin, whether it's spike protein of the virus or the bacteria toxins or the mold myotoxins, is the Th17 overactive. And the neutrophils, of course, that will, Th17 interleukin 6 does activate neutrophilia and neutrophilic inflammation. And that leads to destruction and damage to the body because it's unnecessary. And so when you have overactive inflammation in the body and the immune system is busy producing immune reactions against those toxins and damaging your own tissue and draining the immune system. And when you drain the immune system, you put the patient at risk of having cancer, right? And also you're putting the risk of having other infections because it's unnecessary immune reactions that's causing damage to your tissue. And so this inflammation can affect multi-organs, multi-systemic, and affect many organs of the body. So it's very difficult to really direct those patients to which specialty. I think most of the time they direct them to the immunologist, but it's really to manage those conditions, those multisystemic diseases, because it's a multisystemic disease, and the most near specialty that will be fit to is the immunologist. The problem with the immunologists, they don't have the complete spectrum of how to modulate and how to manage chronic diseases in general. They focusing only on giving cortisone or something that suppress the immune system, and some of them they're smart to give immune modulations, and their immune modulations for the mainstream medicine immunologists, they start giving antibodies that will inhibit the cytokines. So it's a cytokines modulators. But once you give that, there's a risk because those cytokines inhibitors, they may work in decreasing the inflammation here, but it will put the risk of the patients of having infection as well, and especially if you inject it freely, nakedly into the body where it goes everywhere. Now, if you load them inside platelets nanoparticle, I can argue that it's the best way for the immunologist to introduce antibodies or immune modulators. So this chronic inflammatory response can have significant impact on the quality of our life and well-being of affected individual, and can be difficult to diagnose and treat. Yeah, it's very difficult, right? And most of the integrative doctors, um, they are managing these conditions, although they don't know the name of it. They call it, oh, we are managing mold and bacteria and spike protein, and and now we know the term. It's chronic inflammatory immune response, regardless of the antigen, what it is. Could be mold, it could be bacteria toxins from the ticks, from those spirochetes, and from those endogenous bacteria, mycoplasma, rickettsia, or it could be a toxins from the fungus, from all different kind of infection here. And so we're going to learn of how to prevent and manage it, and what are the possible outcome and complication. So this is how we rewrite management of chronic diseases across all medical specialties. Yes, we will go in detail of the pathophysiology, understanding all the pathophysiologic process which affect those four things that we talked about: regenerative, immune, redox, and metabolic. And then we trying to restore them as part of the management of chronic disease. And specifically here, we're talking about chronic inflammatory response syndrome. So stands for chronic inflammatory response syndrome, which is also known as a biotoxic toxin illness or mold illness. And I think, what is the percentage you think, Dr. Joseph, of chronic inflammatory immune response in the United States? Can we say that maybe 20 to 30? What is the percentage, Dr. Patel and Dr. Joseph, you think, affecting the population of the United States and maybe the whole world?
Well, I know that according to Neil Nathan's book, 25% of the people are unable to produce antibodies to mycotoxins. I know that for sure. But pure, like full-blown chronic inflammatory response syndrome, I mean, I would think it's a smaller percentage, because these people are sick.
Yeah, but what would be the population? If anybody has intelligent AI, if you have Bing is good, Chat GPT, and just write, what is the percentage of chronic inflammatory immune response? Can you do that for me? Anybody has intelligent software? Because that's the best way of extracting. And what this AI will go through all the information in the whole net, which represent the 7 billion brains of the humans, right? 7 billion, and they will extract in a few seconds the answer. So just say, what is the percentage of the US or the world population or world percentage of chronic inflammatory immune response? Can you do that as a homework for people who have ChatGPT working on AI while we are talking about this condition? So it's a condition that results from the body inability to eliminate or process the biotoxins. And here's the thing. I mean, is there genetic variations between people in processing and detoxing biotoxins? Yes. That's the reason in one family household, you will see the members of family respond differently to the mold. So not all of them are affected and sick with the mold, right? Because of genetic variations that they have in processing those molds. Some of us have very strong way of detoxing, so they get sick. But other people, they have problem with processing it, and so they get sick. And so, a lot of mainstream medicine say, well, if it's the whole thing, it's biotoxin, and why I don't have it, right? And I live in the same neighborhood and maybe the same load of mold. Or people say, I got affected with COVID, and you got affected with COVID. Why I'm still sick with it? And I have this post-COVID syndrome, and you don't have it. And we both exposed to the same load of virus. It's because of the genetic variation in processing the biotoxins, whether it's spike protein or mycotoxins or others. And so this genetic variation is the reason why we have different response. Um, Again, a biotoxin, whether it's bacteria or mold or fungus or virus, those biotoxin can enter the body through inhalation, ingestion, or skin contact, and can trigger excessive and persistent immune response. And we know what is the immune response that they produce. Th17. Put that in your mind. There is some of them, they have some Th1, some of them they have Th2, but the mainly is Th17. And I want you to put that in the brain, in your mind, because when we manage those patients, in addition to eliminate the source of the toxins, we need to inhibit the Th17. Ivermectin does that, right? Because ivermectin is a Th17 inhibitor. Methylene blue does that. Serotonin reuptake inhibitor, which we use for depression, it does inhibit the Th17. Hydroxychloroquine does inhibit the Th17, right? So all those drugs, antifungal drugs, some of them, they inhibit the Th17, right? They are antibiotic and they inhibit the Th17. And so this overinflammation, especially neutrophilic, this Th17 hyperinflammation, it damages the tissue of the body. And we know this condition affect all ages, all genders, all ethnicity. But as I said here in this book very clearly, some people are genetically more predisposed to this disease than others. And the reason, because their genetic expression of the antioxidants and all those machines that are responsible for detoxing those toxins, there is genetic variation from one person to another. Most of the time, the brown and black people, they have more stronger detoxing process than the white. The white, most of the time, the white are very sensitive to the detoxing process, and that has a lot of things to do with, even there is some variation with high income class and low income class, and people are savvy, hygienic, that clean them, they clean too much, they don't expose their immune system, are more reactive to the environment, and so we see those high class, their kids are not being exposed to the dirt, they don't play outside, everything is wash your hand, clean, not exposed. So what happened is that their immune system is not being exposed and not tolerance, and they're not being trained to detoxify and clarify those germs. So sometimes too much of hygiene is not good. I'm not saying hygiene is way to go, but that we need to be exposed to the environment, playing on the ground and things like that, and having our kids to go out and interact with the nature. It's part of training your immune system to get stronger, and also the detox process as well. But at the same time, does not mean that exposing yourself to the mold and exposing yourself to infection and COVID and all that stuff. We need to come up with some reasonable approach here. So what are the symptoms of the chronic inflammatory response syndrome? It goes range of symptoms. That's why it's very difficult for the patient to be directed to which specialty. I mean, if you see it, it's affecting all the systems. It's causing fatigue, it's causing cognitive impairment. So we go to the neurologist. Okay, well, it causes the mood disturbance. You go to the psychologist. It's causing headache and migraine. We go to neurologist. Oh, it's causing respiratory problems. So let's go to the pulmonologist, right? Or you want to go to the GI, which is the gastroenterologist, or you want to go to the dermatologist. So it's affecting all the systems. And that's the reason why we come up with this new medical specialty of chronic disease prevention management, which means that all those people who are being trained and become specialists, they can have a degree, a fellowship with us as chronic disease prevention management, and they can tackle those multisystemic disease more effectively than being a specialist. So it's a kind of a degree. We can come up with a PhD degree for chronic disease prevention management. That's the plan that I'm trying to do with Bob, with Dr. Bob and Dr. Baby Klatz, to come up with a fellowship or a PhD degree for this field of medicine that's being entertained by American Medical Association. So again, if you see it definitely, the patient will be having all this multisystemic. Is difficult even to direct them to where they go. Is it going to neurologist, pulmonologist, cardiologist, vision, hearing, ophthalmologist? So if we receive those training, then we can manage it. And then if you receive this training and you start managing it as chronic disease prevention management specialist, then the other specialists who are next door to you will not be complaining to the board and say, hey, he's managing a neurological disease, right? You know, I have a degree in chronic disease prevention management, and this patient has multisystemic disease. So yes, I can manage those patients who are suffering from headache or migraine based on the training that you received. So that's the whole purpose. And it definitely helps to broaden the spectrum of your knowledge and also the patients that you see, and you can have better, more confidence in managing chronic disease. Because if you manage it through specialists, trust me, the way that we train, it's going to be tunnel vision, and you cannot effectively manage the patient. Why? Because if you say I have Alzheimer and I'm going to manage it just to increase acetylcholine by inhibiting acetylcholine esterase and giving them tacrin, which is the drug that you use, and go home, well, yeah, but Alzheimer's it can be aggravated by leaky gut. It can be aggravated by mold. It can be aggravated by toxins. It can be aggravated by imbalance in the hormone system. It can be aggravated by the opioids that the patient is receiving from the pain management. It can be aggravated by rheumatological disease that the patient is suffering, or from diabetic, or from whatever hypertension the patient has. So understanding that Alzheimer it's not just an acetylcholine esterase inhibitor problem. That's one of the pathophysiology of affecting Alzheimer, but Alzheimer is affected by many factors that aggravate, trigger, and speed the progress of Alzheimer. And if we tackle it with the approach of the chronic disease prevention, with the 4 pillars, with the 4 key notes, or the 4 keys that we learned, which is restoring the redox, metabolic, immune, regenerative, and part of restoring metabolic, yes, is increase acetylcholine esterase, or inhibit acetylcholine esterase and increase acetylcholine bioavailability, but that's not enough. If there's deficiency of 6 hormones, you need to manage that. If there's deficiency of vitamin D, you need to give it that patients. Vitamin A, leaky gut, toxins, you need to manage it. And all of this will definitely help to optimize the health of the patient and manage the Alzheimer better than what the mainstream medicine does in managing Alzheimer's disease. That is the reason we need to be specialists, or we need to have this fellowship, and possibly a PhD degree with 3 years in this field of medicine. The question is that we have the fellowship now. Can we advance it to become PhD degree, or can we advance it to become residency program? That is the things that I'm working with my team. And the way that you can be contributing here is helping me with the textbook, helping me to get the funds. You remember redefining the health system, is there's 6 pillars that we talked about. Is you have to have finance and funding, and you have to come up with protocols and a textbook as a guide. And also all of us, we need to contribute and collaborate. Those are the pillars, or the way that we can redefine and coming up with some better medicine for, or upgrade the medicine that we are giving to the patient. So what is the symptoms of the chronic inflammatory response syndrome? It's a chronic, intermittent, or acute, and can vary in severity and frequency. They can also mimic or overlap with other conditions. That's the problem, because it's affecting multisystemic here. You can come up with chronic fatigue. You can come up in a form of fibromyalgia, Lyme disease, right? It can be multiple sclerosis, right? Patients may have some genetic of multiple sclerosis, but it's being aggravated by those ticks or those fungus or those spike protein, and so it manifests as a form of a full-blown disease. So this combination of this environmental exposure to the biotoxins maybe itself will lead to this condition, or it may trigger and aggravate any subclinical condition. Let's say the patient will not have the Alzheimer's disease until the age of 80, genetically, until the age of 80. But he's been exposed to COVID or being exposed to the mold, and now he have it at age of 50. So who triggered that disease? All right? It's the chronic inflammatory response and made it worse, right? Or patient has Alzheimer, but it's not progressing. But when he got COVID or mold, it's rapidly progressing, right? And so there is an overlap between all this, and they may manifest in the form of, known diseases that we recognize in the mainstream medicine as Alzheimer or multiple sclerosis, etc. So what are the causes of chronic inflammatory response syndrome? It's caused by exposure to biotoxins. We talked about biotoxins, could be bacteria, right? Debris of the bacteria, toxins coming from the bacteria. We're going lipopolysaccharides of the bacteria, right? Or it could be spike protein of the virus. It could be mycotoxins. It could be any toxins from the algae or parasites. So those biotoxins can be found in various natural or man-made environments, such as moldy, water-damaged buildings, such as homes and schools, right? Especially in Michigan, where in the forest, where people living, Amish people. I've been treating Amish people a lot, and they, they avoid the 5G and all the electrical damage that we have in modern lifestyle that we have by avoiding any electricity going to the home, right? Because of the electromagnetic wave that's coming from the electric and Wi-Fi, all that's prohibited for them. They don't use it. But where's the problem that they have is that their houses is full of mold, right? Because they live in the farms and in the wild and the forest. And yes, we solve this problem by avoiding the 5G and electricity and all that stuff, and Wi-Fi, which is a source of oxidative stress, but also you end up with exposing by living in the farm with black molds and all those infections. So it's kind of so we need to come up with something in between where we still have exposure to the nature, but not to the point where we be living in a house that's contaminated with especially the black mold. It just all of the houses of the Amish people do have black molds, most of them. Contaminated water such as lakes, rivers, oceans, infected animals, right? All this can be source. We know the Lyme disease coming from the deers, the white-tailed deers that we have in Pennsylvania. That's the reason I like to hunt deer, but all the time I start thinking, well, what about the ticks of Lyme and all that stuff? But again, being affected by Lyme disease is genetically vary from one person to another. Okay, maybe I have enough detoxification where I can combat the biotoxins of Lyme. So contaminated medical device or implants such as breast implants, pacemakers, especially those people who are doing wrong things in medicine. No, not everyone who is exposed to biotoxin will develop chronic inflammatory response syndrome, right? Because of the genetic variations. And we find out that white people, yes, they're more sensitive to the biotoxins than the colored people for some reason. I don't know, but I witnessed that from the patients when I was doing pain management. Most of the time, the white are more sensitive than the Spanish and the Black people, for some reason, could be genetically, or because maybe the white people, they are most of the time they are of the high class, and they are not being exposed to the environment, and their immune system are not being trained to detox. That's another explanation. Um, okay, so uh, okay. So chronic inflammatory response include, however, some factors that increase the risk of severity of chronic inflammatory: genetic susceptibility. Some people may have genetic variation that affect their ability to recognize and process and detox the biotoxins, right, from their body. So we have genetic variation. So if you see in a household, one is sick from the mold, another one, his brother is not, okay, or his sister, it's because of genetic variations. Or two houses in the neighborhood, and both of them, they are mold. The house are mold, but one family or the house of this family members or the members of this family are not affected. The other one is affected. So that indicate there is some genetic variations in the way that we respond to those biotoxins. So this can be make more prone to develop the chronic inflammatory response or experience more severe symptoms than others. Even for COVID, So I have COVID. I don't have post-COVID syndrome, but other person who was next to me has the problem, and that's because the genetic variation in processing and responding to those spike protein is different. So this genetic variation known as HLA-DR and can be tested through a blood test. So that's the point. Now here's the thing: in order to know that this patient is more prone to having a chronic inflammatory response, then we can do some genetic testing and say, oh, you are more prone to having chronic inflammatory response to spike protein or to the mold or to the Lyme. And here's the problem that you have in genetics. That's the reason why you have problem with your detoxing and processing and recognizing. And so that's the reason we need to do those genetic testing. Helps us to identify people who are more prone to the chronic inflammatory immune response. And it helps us in diagnosis. Then that will confirm it. If the patient come up with all the symptoms and they have genetic variations that makes them more prone, then you can say, hey, with confidence, this guy does has chronic inflammatory response because of the genetic issues of genetic testing that confirm that he is at risk of those symptoms or those conditions. Again, the difference is in duration, intensity of exposure, right? That's easy. People are being exposed to overload of spike protein versus some people are not. And so you can see these patients may have suffer from post-COVID because of the load of the exposure to those biotoxins. And so the more a load of exposure of mold in the house, let's say there's two houses, right? Maybe they have the same genetics, but one houses have more mold than the others. That could be a factor as well. So, for example, living for working in a moldy or water damaged building for a long time can increase the risk of chronic inflammatory response, right? So I live in a good house. Genetically, I'm prone to chronic inflammatory response, but you live in the farmer, and genetically you're not. But because you have too much of mold, that makes you at risk of having chronic inflammatory immune response. Although genetically, maybe where you mean same, but I live in free mold house and you live in a mold house, so you have more high risk of having. So it's a combination of genetic and environment here. It's not just genetic. Co-exposure to other toxins. Yeah, if somebody has mold and then he got COVID, yeah, so now the patient is responding to two kind of biotoxins, and that will be synergistic. They add together, right? So if patient has mold already and is being COVID and being exposed to COVID, he's got more worse his condition. His Alzheimer got worse, his diabetic got worse, his multiple sclerosis got worse. Well, because you have two factors here that synergistically adding more inflammation. And again, the inflammation of COVID is Th17 hyperinflammation. The inflammation of fungus is Th17 hyperinflammation. So both of them, they converge into aggravating the Th17, the interleukin-6. Co-infection, comorbidity. Okay, what about a patient has diabetic and then has mold, right? Yeah, the diabetic will put them more risk of having chronic inflammatory because they are immune compromised from the condition itself. So having other infection or diseases such as viral, bacterial, or fungal, or diabetes or hypertension or anything, that compromise the immune system, that put them at risk of having chronic inflammatory. And so this infection or co-infection or disease compromise the immune system and inflammatory response, making it more susceptible to biotoxins. Of course, the diabetic patients, they will be immune, they are immune compromised, and if they've been exposed to the toxins, they definitely will have more risk of, or more chance of having chronic inflammatory diseases. Is everybody happy here? Making sure that you're not sleeping? Are you entertained?
No, this is actually really good because it's really now coming full circle. You know, you remember back when at the beginning of the pandemic and they were talking about post-COVID fatigue, and it was like all these different random symptoms, and some patients had this and some patients had this, and they had a list of 200 different symptoms. And it's like, you know, you would just see, you know, in the news or news, oh, doctors just don't know what it is. But when you understand chronic inflammatory response syndrome, and you understand that there's other toxins and, you know, mold toxicity, and this is what I learned from Dr. Patel. You know, she used the metaphor, the straw that broke the camel's back, right? Meaning that the toxic load may have been at a certain level, like there may have already have been mold exposure, mycotoxins, maybe some heavy metals, maybe even a little bit of Lyme disease. And then all of a sudden you get COVID, boom, drops the immune system up. Epstein-Barr becomes active, Lyme becomes active. The mold is producing more mycotoxins. It's all of a sudden you go over this threshold, and all of a sudden you're just sick. You're just completely sick. Whereas before you were probably more fatigued than you thought you were. Okay, I could speak for myself. There was a certain level of fatigue that was manageable, that, you know, that I could say I was used to. But then suddenly COVID came around and it was like game over.
Right. I agree with you 100%. I mean, I think everybody here, and I think that's the reason American Medical Association did recognize that there is a gap in all our medical specialties in managing COVID and COVID symptoms. And they came up with this 360 pH, which is redefining the way we take history and physical exam to include all the systems and all the stressors, whether it's social stressors or biological stressors. We call them biosocial stressors. And be more comprehensive in collecting the data and information, because all those systems can interact with each other. And if you have a condition in one system, other systems are sick, they may aggravate that condition. And so treating the body as whole and screening for all the inflammatory sources or all the leakage of the free radicals, and then neutralizing them by removing the source of the toxins and the damage, and neutralizing those free radicals and balancing the immune system and balancing the metabolic and restore the regenerative status of the patient as the pillars of the chronic disease prevention. I think this is the approach that we need to take when we manage chronic diseases. So let's start with saying, what is the first thing we need to do? Now, the other thing is that, which is a good thing, and I meet everybody here. We have 20, 21 people here in this room. I want you to search by your artificial intelligence, because the language of today is artificial intelligence. And what artificial intelligence, it gives you the information out of all the website information out there from all different academies, from all different universities. Think about all the schools of all different countries, of all different backgrounds. All of it is now in the air, in the web, right? In the websites. And the AI goes to all of them, and in a few seconds you get the answer. And the answer most of the time it's correct. And the reason, because in research, when we do research, what is we have stages for research. We have the clinical case, cohort study, but the best thing is the meta-analysis, right? The meta-analysis where you take all the clinical trials that's being conducted for a certain condition from all different researches, like 100, 1,000 clinical studies, case control has been done. And then the meta-analysis will take the results of all of this. The same thing with artificial intelligence. It's the highest way of extracting the truth, because it will study all the results and all the background and all the conclusions of all the studies that has been done up to now, and tells you the abstract, exact what's happening. So I need to know, what is the medical code? Do we have a medical code for chronic inflammatory response syndrome? Can you do a favor for me, Dr. Joseph Batal, and search if we have a medical code? Because that's very important, especially people dealing with insurance, and even for private, is to have a medical code for the condition as a diagnosis, recognized, diagnosed by mainstream medicine. I don't know if the chronic inflammatory response syndrome has a code or not. I did not search it, but I want the 20 people here to go ahead and do that for me and come up with that code. And if you have the code, please come up to the mic and tell us the code. Because it's very critical, because that code helps especially when you're trying to do testing and you want insurance to pay for it. They will ask you, okay, so what's the diagnosis? What's the medical code, right? And it helps you to come up with the medical necessity that the insurance will pay for it if there is a medical code. If you don't have medical code, it's not recognized, they don't pay for it. So how we prevent and manage chronic inflammatory response syndrome. We talked about pathophysiology here and some of the epidemiology here. Let's talk about how we manage it. Managing it, number one, is identifying and removing the source of exposure. That's very important. So if you've been living in a house with mold, you need to go ahead and clear that house from the mold, or move to other place, right? That's what I recommend Dr. Joseph to move from Michigan, from the farm that he lives in, maybe moving to the south to Florida next to Dr. Klatz will be a good idea, next to the beach. Now, here's the problem. If you move yourself from the mold, but then you live in those towers, which are full of electrical grids and electrical wires, then you'll be in the Wi-Fi, then you have the stressors of the 5G. So it's best if you find a place where it's in the middle, suburban area, where there is no mold, plus there's no much of that electrical wiring thing. So this is the first and most important steps in treating chronic inflammatory response. Source of exposure could be the moldy, water damage building, ticks, spider bites, other environment toxins. We need to find it, identify it, and definitely remove the source. The person should avoid or eliminate contact with the source of such as much as possible, right? If you have mold, if you have area where there's a lot of ticks and Lyme disease, and you have problem in processing it, then you need to find an area or move to the area where they don't have that infestation, and take measure to remediate or decontaminate the affected environment or sources. That would be good. That's one. If you cannot afford to move to other places, then work on clearing your house from the mold, and having mold inspector, which are expensive, testing and treating. And if there is source of mold that needs, especially if you have genetic, and that's good, you test your genetics and see if you have a problem there, then that is the reason why the patient is, that confirmed the reason why the patient.
Okay, so I did put on the group message that there is an ICD code for chronic inflammatory response syndrome. It's R65.1. So
good.
it's according to Bing. Okay, we should say according to Bing. Okay.
Right.
And the other thing is interesting is in Neil Nathan's book on mold toxicity, he does mention that it's not really the molds in nature as much that are toxic to humans. It's the ones that grow in the house, the particular species that tend to survive in, water damaged buildings. Those are the dangerous ones. And I believe they said, in nature that the molds are just, they're creating the mycotoxins really against each other to compete with each other, for resources, I guess you could say. But there's only certain species that tend to grow in the materials of the housing in water damaged buildings. So that's something that I picked up from the book that really stood out for me.
Yeah, that stuff is called Stachybotrys. It's the black mold.
Right. So,
yeah,
so
I mean,
what we
obviously,
need, right.
I mean, there's more species, but he's right that that's one of the most common ones.
Right. And I think we need to test it, and there's several tests that can help to diagnose chronic inflammatory response syndrome. And those testing is to diagnose the agent that caused the problem, that the antigens of the mold or antigen of the bacteria toxins or of the Lyme, right? There's a lot of genetic testing and DNA testing that you can do for the RNAs of those ticks. There's genetic testing you can do, DNA testing, and also you need to check the immune markers, right? See if there's any inflammatory, especially interleukin-6 and Th17 cytokine profile and lymphocyte mapping will help to see the imbalance in the immune system and what will be the next step to balance the immune system. And most of the time you will see that they have hyper Th17, or they may have a problem with their B cells and B cells are low. So possibly because of the Epstein-Barr virus. So all of this, you can test the antigen, the germs, and also the inflammatory immune response by checking the immune markers that we know, right? Those inflammatory markers. And if the inflammatory markers like erythrocyte sedimentation rate, all that, maybe you can find them normal, then you can go dig deep and you can do lymphocyte mapping and cytokine profile to find out exactly where the immune is being imbalanced. So that is very important.
I would highly recommend a lymphocyte map, because when I got a lymphocyte map for myself, and I'm going to present it in one of these lectures, is that my lymphocytes were very low. My CD4 count was almost that of an AIDS patient. I mean, it was scary. And my B cells were really low, which was also creepy. And then, of course, according to my Array 12, it did show I had high levels of mold, IgG, Stachybotrys, penicillium, a little bit of Aspergillus. I had Epstein-Barr was active. Herpes type 6 was moderately present. And I believe a couple, maybe even possibly a Lyme species. So, I mean, it's real. Like, and when I did a genetic test, number one thing was like I mean, it was like high levels of inflammation. And then the second biggest problem was detoxification difficulty. And then, when I would make PRP out of my blood, and my PRP was very cloudy. So, I mean, I'm an inflammatory factory, literally. But here's my thing. You don't know where you stand. If somebody has fatigue issues or any of those symptoms, you don't realize what's going on unless you get a lymphocyte map and look at your pathogens, because you don't know what chronic pathogens that you have. You may not realize that you are immunocompromised. And it's not obvious on a regular CBC, by the way. Even with the differential, the numbers are different. But a lymphocyte will make, like, you're not going to see a CD4 count on a CBC. So you're missing big pieces of the puzzle when you're looking at just a CBC and differential, and you don't know what chronic pathogens you're harboring. That's the trick. Because if you're not better and you think, well, I need to do this, or I need to add this nutrient, or it's all about diet. I know I come off like that. I only say that because if you don't know what chronic pathogens you have, you're missing the point. It's not saying, oh, I need to learn sound therapy and fix everything with sound therapy. That's the answer. That's just shooting. That's another form of shooting in the dark. It's a good thing, but if you don't know what chronic pathogens are active, you don't know what's going on.
Right. So what we need is that we need to treat the inflammation and remove the toxins, right? And that's the main goal of the treatment: reduce the inflammation, remove the biotoxin from the body as much as you can. And this can be done by anti-inflammatory. Now, anti-inflammatory for the mainstream medicine is NSAID and steroids, right? But the problem with NSAID and steroids, it does suppress the immune system to the point put you at risk of having infection, compromise the immune system. So can we modulate the immune system without suppressing it? Modulating it without suppressing it. What does that mean? Especially if you go to lymphocyte mapping, you will say, okay, well, there's inflammation, but there's too much of Th17. So, and there is a little bit too much, not that much of Th1, but maybe too much of Th2. So what I will just go ahead and inhibit the Th17 and not messing up with Th1, because steroids will suppress the whole thing and then will put you at risk of having cancer infection if you give steroids. If you give NSAID, it will suppress the inflammation, but at the same time, it affect your kidneys, and you will end up with renal failure. Of course, you end up with kidney failure and GI hemorrhage and all that, because it works on prostaglandins. So what we need is to have agents that's anti-inflammatory that modulate the immune system without suppressing it. And so all the polyphenols, they're very good in inhibiting the Th17. So I will use all the polyphenols out there, right? Including some of those healthy omega-3 fatty acid, polyphenols, curcumin, quercetin, resveratrol. Those are polyphenols. And what they do, they don't inhibit too much of Th17, or they don't suppress the immune system and compromising it. They modulate it and normalizing it, where they inhibit the excess of the or the hyperinflammation without causing immune compromising. And quercetin, resveratrol, this polyphenol would be great. Low dose naltrexone will be also good. That helps to inhibit the Th17. If you want to say, I want to give ivermectin because it inhibits the Th17, that's good. Methylene blue, give them methylene blue, put them in the bed of the red bed. So all of this agent can help to modulate the inflammatory response and protect the cells and tissue from further damaging.
Let me chime in here. Just from my personal experience, that level of inflammation that I had, okay, I'm a lot better than, before. I was in a really bad place as far as just my energy, and I couldn't think straight. It was difficult for me. My word finding was bad. I still struggle with that to a degree. What I can say is none of that works. I mean, it's making a difference, but I can absolutely tell you, I took quercetin, I took resveratrol, I took all of these things, and it does nothing. It doesn't even touch it. Not the high level, not the really, really sick people. That's why I had to do injections of Kenalog until I learned, try the hydrocortisone. And that's when I stumbled upon Amlexinox and then dimethyl fumarate. So you have the steroids without the steroid, without the bad side effects. But the stuff that you think should work for the people who actually experience this stuff does nothing, not at all, nothing. You'll never feel anything. I think you get the message, but it doesn't mean it's not the wrong thing. But unless you've been through it, you won't feel a difference with any of that stuff. You need something stronger.
Right. And that's something that, because this is most of the text here is produced by the AI. That's where when we rotate this book, you're going to say, okay, in addition to that, we need amloxanox, the fumarate, we need oxytocin, we need methylene blue, we need low dose hydrocortisone. So that's where all the doctors here will be more smarter than the AI, and they will punch their experience and skill once you have the platform being written nicely in front of you. Just punch those things that you think it's missing, and we can come up with a book that has all the visions and skills and experience from all the doctors who are contributing and writing the book.
And then one other thing, just one last thing to say, and this is the context that I come from. I'm all about exercise. I've always been an athlete, but when you're in that state, you have true mitochondrial dysfunction. You cannot hardly do anything. You try to walking is difficult. Balance is off. Try to jog. I could jog maybe a block, maybe two. You're short of breath. I don't have asthma. Okay, that's how bad. So when people think, okay, no, you just need to get up and you need to exercise, you've got mitochondrial dysfunction. You're worsening the inflammation. So you have to either experience this yourself, or you're going to have to treat a lot of patients and really understand that it's not in their head. It's not that, they just need to get up and exercise. I'm all about exercise. But when you're that sick, and some people, remember, there are actually people who are debilitated. There's people with Parkinson's disease. They cannot just get up and go jog 10 miles. Okay, so we have to wrap our heads around this better and understand, that this is a big topic. This is a very big topic right here. This is expanding the reality and getting you into the experience of what this really is. Go ahead.
Yeah, how do you prove though that they have the mitochondrial disease and they're just not making it up?
No, I'm just saying, look, when somebody look, I told you what my lymphocyte map looked like, right? And I told you what my pathogen profile looked like, and I told you the symptoms, and I had very high levels of inflammation. Well, when you have very high levels of inflammation, you have high levels of oxidative stress. I understand what your question is. I think it's a good idea to measure it. I mentioned it as a clinical diagnosis, a mitochondrial dysfunction, because it was like I had no energy. So if that's not mitochondrial dysfunction, I'm not sure what it is.
Right.
Dr. Joseph, what did you do to help that? Or what are you doing for the mitochondrial dysfunction? I think this is more common than we want to believe. And I've got people like that. My best friend, who is a pharmacist and a chiropractor and whatever else this week, is suffering from this. He's very alternatively oriented and is struggling with mitochondrial dysfunction. And we're going through everything, from cold therapy to intermittent or time restricted eating to sleep, and exercise, as you say, is almost impossible. It's like walking downstairs to the kitchen and he's wiped out. So what did you do, or what do you recommend for this, besides taking MitoPure or one of those supplements?
Yeah, because the MitoPure isn't gonna touch it either.
Yeah.
I kind of had to do trial and error. And I mean, the thing that worked great, I tell you, is a shot of catalog. I mean, it's like a shot of catalog, and it was like a few days later, it's like feeling like you're in heaven because you feel normal for a while. But then, then I became dependent on it. And then I was starting to develop, some of the moon face and things like that. So then hydrocortisone, it was a process. So I think if I could do it again and I could have this understanding, well, you have to go straight for getting rid of boost up the immune. Okay, here's a good one. Boost up the immune system with thymolin. Okay, so you got to boost. Yeah. It boosts the Th1 and the Th2, so you get boosting of the B cells and the T cells, so that you can put some of those chronic pathogens back into remission, like the Epstein-Barr and some of those other chronic viruses, and maybe help with the Lyme if you have that. I was not savvy at that time as far as understanding how to bind mycotoxins so that they don't just recirculate from the gut back into the bloodstream and keep inflaming the body, and realizing that different species produce different mycotoxins, and different binders bind different mycotoxins. So you have to have a strategy for binding them, infrared sauna to sweat them out. That helps. So you're tackling to me, it's the most important thing. You've got and keep in mind, thymolin is anti-inflammatory as well. So you're going after the lymphopenia. You're modulating Th17 with, I guess you could say, ivermectin, and with methylene blue. The thymolin mate is also modulating that. Amlexinox, that modulates the Th17. Dimethyl fumarate also reverses the Warburg effect. So that's like the next level. Okay, so that's going to help with cellular respiration and mitochondrial dysfunction. And it's activating the master regulator of oxidative stress.
You didn't happen to try ozone, did you?
I had tried ozone, and it's like nothing made a dramatic difference. Now, I can't say that I did ozone enough to fix it. I don't know if ozone by itself could have fixed it. I can only speculate. But what did actually jumpstart things for me by luck, well, just, it wasn't pure luck, but is when I did a shot of Kenalog, and then I took high doses of 5-amino 1-MQ to sort of rescue the NAD plus salvage pathway.
Yeah, that was my next
question. You have to imagine that. Yeah, and all of a sudden, 5 days later, no, I had been taking the 5-amino for about I was going on a couple of weeks, and then I upped the dose, and I had done a shot of Kenalog, and it was like, it's like having a blocked pathway that suddenly I opened up an important enough of a pathway, the NAD plus pathway, such that it may have been enough to activate the sirtuin genes to flip on to AMPK and generate heat from the mitochondria. All of a sudden, it was like night and day.
Yeah.
And I was able to go with that momentum and sort of get myself to a place where I didn't really ever go back.
Right.
But I didn't have all the other pieces of the puzzle put together in my head. So those are the major ones. If I have to just speak to that off the top of my head, those were the major things.
Yeah. Well, for those people who don't know, Kenalog is a major, powerful steroid. That's probably the most powerful one we have.
Right. We will try. I mean, I'm not again giving cortisone low dose or hydrocortisone, but we need to avoid taking it for a long period of time because it will suppress the immune system and compromise. But giving physiological level, I think it's okay, or giving it in acute condition. But adding polyphenols and other things that we're going to talk about, as we see here, that in order to detox the body, that's why the reason why Dr. Mike Emanuel, we come up with detox at night, which is everybody needs to be detoxing at night, because that's the best thing. Take a capsule of activated charcoal and zeolite, which is the clay, along with chlorophyll, and possibly adding the carnosine, N-acetylcarnosine, to inhibit the glycations, the oxidation of the sugar. So if we get these 4 ingredients every night, then we have something that will help the detoxification process of the sleep. So, and those are binders. You can add cholestyramine, also especially for mold infections, and all of this helps to detox and bind those toxins and and help the process of the processing and detoxifying biotoxins. Now, as Dr. Joseph said, that the sauna, sweating out the toxins, exercise, hydration, aquatherapy, a low calorie diet, all of this helps in process of detoxification, making sure that the food that you're eating are healthy. So generally optimizing the health and detoxifying the body is a way that we can
I'm,
manage those conditions.
and I'm gonna recommend that we put an emphasis in addition to that, that when somebody has the immune system, lymphopenia at the level of close to AIDS, okay, I'm not exaggerating when I say I'm talking, I had a CD4 count of 364. And if the problem is coming from all the biotoxins, from all those chronic infections, I mean, I was under attack. So
Yeah.
we have to restore the immune system, and the only way that I know how is through the thymosins. I mean, we had thymosin alpha and thymosin beta. Of course, the FDA, they take that away. I mean, they really drive that dagger, and you say, "Ha! You thought you were smart. Now we can't boost up your immune system." Fortunately, we have thymolin, or we can get thymosin alpha from the places that are not for humans and animals, but that they're okay. But I would say that we have to put a special emphasis on restoring the immune system, because otherwise those chronic pathogens will stay active and keep producing those biotoxins, which are inflaming the body, which are destroying it and degenerating
Totally.
the patient.
Right, and that's what we're gonna be talking about it at the end of this chapter or this page, emphasizing on immune modulation, immune boosting there. But in generally speaking, the thing that we can use or recommend is detoxing, the sauna, exercising, all this good will help, along with, as I said, those hard stuff that we talked about, which does not have side effects like those thymosin alpha or thymolin and things like that. But very important is detoxing. That's very critical. That's the reason having a capsule that contain activated charcoal, zeolite, chlorophyll, and acetyl carnosine, that would be something that would be great. I mean, Dr. Mike Emanuel, if you're listening, can you come up with this capsule of detox? Everybody here will be on it, especially the carnosine. The carnosine, it's very important because of the oxidation of the carbohydrate and sugar of our cells, which leads to glycations. And the glycation is the reason of aging and reason of all this um, um, process of aging. Part of it, a big part of it, is the glycations. And if we can stop Alzheimer, if we can stop the process, then help to reverse the aging process dramatically. And that's the reason I'm using eye drops of carnosine for cataract, to slow the process of cataract. Because when we get to the age of 50, you get the cataract, and cataract is glycations, and carnosine inhibits that. And that's the reason. And I learned this from Dr. Rose Mark. I don't know if he's here or not, but he's the one who told me, hey, I told them start having cataract, what they can do. See, we're learning from each other here, right? And he say, go get eye drop of carnosine. This is what I do. I'm an ophthalmologist for many years, and only thing that works for slowing the process of cataract is carnosine. Maybe we're gonna create an eye drops of carnosine and losartan, and will be standard treatment for glaucoma and for cataract and for many eye degenerative diseases. I'm working on that part with compounding.
A couple of things, because now my mind is going wild, and I hope this is painting a better picture of some of these confusing case presentations, or even when I talk about this stuff, I hope it's making more sense. Some of those mycotoxins actually block like complex 1 of the electron transport chain. So all those toxins are blocking various pathways, methylation pathways, within the electron transport chain. But I was going to say, darn it, I had it. Just give me a quick second here. Oh, so, and there are people who have it worse when it comes to detoxification. And because I treat a lot of patients that have a mercury toxicity, you'll see the mercury toxicity people, they have other things too. They've got mold, they've got Lyme, they've got a combination. They are poor detoxifiers. And you know, the one thing, the lifesaver for the extreme cases, these are people they almost cannot eat, is a map. You have to think, and these are the people who have like panic attacks and terror attacks and they can't eat. They're extremely inflamed and they've got the mast cell activation syndrome as a bigger part of the overall process. I mean, I have it too, but there's it's called ketotifen, and for these people, they have to be on ketotifen 4 times a day to control at 2 milligrams to control those mast cells, to control their panic attacks, to be able to eat. Then we give them BPC 157 and KPV. Even though the FDA tried to take that away, we still have the orals. Haha. Thymolin is great because they usually have some degree of immune suppression and it's anti-inflammatory for the gut. But it can get to the point where a person needs to be on ketotifen 2 milligrams 4 times a day. It's an antihistamine and it stabilizes the mast cells. And Lexinox helps, but it's not strong enough like ketotifen. So for the severe cases, that's where they have to resort. If they don't do ketotifen, like nothing else they're not going to get from here to there. So we have to remember there's an order of urgency and importance to do certain things before the other things will start to work. You see what I mean?
Yeah, exactly. Yeah.
I hope
Awesome.
Dr. Mike Emanuel is here. He's listening all of this so he can translate
Yeah.
this into formulations. We used to have Mike Beamer doing it, but Mike Beamer is working with Will's Pharmacy, and Will's Pharmacy, they're too big for and they are busy with the orders that they have, so it's hard for them to break through new things. But Dr. Mike Emanuel here is taking over till Mike Beamer comes back, maybe, and we can all work together. But I hope that Mike Emanuel is hearing you and listening to you, so he can come up with new formulations that's being recommended in this platform of education. But again, when we trying to manage any chronic disease, there's 4 key pillars that we talked about: redox, metabolic, immune modulation, generative, are very important to be restored, right? And that's what we are throughout the book. You will see that emphasis on those 4 things, and that's the blueprint of this new field of medicine. And everything that we talked about, it can be categorized under those 4. Now, if we miss any treatment, that's why we're going to circulate these books to all the doctors, like Dr. Joseph James, Dr. Quinn, Dr. Patel, Dr. Mike Beamer, Klatz, all the people here who are interested to be part of this book. They will be circulated, and they can punch in the more information. So it needs to be edited, and we add your own spices here. But again, those are the 4 things. Those are the unique things about the book, why it's necessary to have this book, because it covers things that's unmet, and it's a new thing, it's a trend, and it covers every treatment out there that we are giving to the patient, but with understanding of exactly what we're doing to the body and how we are heading restoring and optimizing the health and managing the pathophysiology. So these are advanced therapies that aims to restore the balance and function of the body systems that are affected by chronic inflammatory response syndrome. Redox therapy involves using antioxidants such as glutathione, vitamin C, and acetylcysteine to counteract oxidative stress and free radical damages caused by the inflammation. So that's one thing. And then there's many things that you can add. You can add methylene blue there. Oxidative stress are free radicals that impair the cellular function, cause aging and diseases. And antioxidants, as we talked about, polyphenols and carnosines, help to scavenge those free radicals and protect the cells and tissue from the oxidative damage. Metabolic therapy involves using nutrients, anything that endogenously, any metabolites that's endogenously produced by the body is deficient, like vitamin D, B12, anything that endogenously that your body is deficient. That's called metabolic, including sex hormones. So replacing and replenishing amino acids, CoQ10, magnesium, those are endogenous products. Vitamin B12, that's under metabolic to support the energy production, cellular function of the mitochondria and the powerhouse of the cell. So we mentioned that. I think Dr. Joseph is talking about it's very important to activate the mitochondria. And so this is part of the management of chronic inflammatory immune response, is to
Dr. H?
restore the health of the mitochondria. Yes, go ahead.
Yeah, I'm going to throw in one more thing. If we look at this upstream, and I'm always harping on this kind of thing, I think one of the first things we have to do for people is get them to eliminate, if possible, sugar, starch, and especially fructose that's in these soft drinks and some other things. This, as you know, spikes insulin and all that, which causes inflammation, which now we're in a vicious cycle. You got the advanced glycation end products with the sugar combining with any protein that's there, total inflammation, which is going to cause the immune system to be kind of what would you say, waylaid into trying to fight that and trying to fight other toxins. And that's when I think that your energy just goes in the toilet.
Right. So that's something we're going to add to this. So when you get this book, you go, okay, well, low carb diet is also critical here, and keto diet, and you can go ahead and insert that. So mitochondria are responsible for generating energy, so it needs to be optimized. So those biotoxins, inflammation can damage the mitochondria and causing mitochondrial damage. And you need to restore it by giving all the nutrition that helps to restore the mitochondria and restore their function. And of course, if you have a problem with your mitochondria, you will have this fatigue and weakness, and that's the reason you cannot exercise and all that. So giving all this, replenish all this nutritions and empower the body. Also, you can add light therapy, ozone therapy, all this helps to activate the mitochondria. You can add the NAD precursors, right? And so there's many things that you can be creative here. And if you want to punch in all this information, free to do that once you receive the copy. Nutrients can help to repair and restore the mitochondrial function, enhance the energy and metabolism of the cells. So the other thing is that we need to modulate the immune system. And the best way to detect where is the imbalance of the immune system is to do cytokine profiling and lymphocyte mapping. That's Dr. Joseph is telling you, hey, if you do CBC differential, you may see it all normal. But if you do the cytokine profile and lymphocyte mapping, that will definitely show you exactly where the immune balance is. And then if you see that, oh, we have low B cells, maybe because of Epstein-Barr virus, let's go ahead and give methylene blue so we kill that virus, and possibly that will help to regain the function of the B cells. Or you have too much of Th17 interleukin-6, let's go ahead and give things that inhibit the Th17, like low dose naltrexone. One is the thing that we are doing a lot. Intravenous immunoglobulins, those are the mainstream medicine. They like to do it. But if you do it, it's better if it's being loaded inside the platelets nanoparticle, because all those anti-immunoglobulins, they have side effects, especially if you inject it, it goes all over. You want to target those immunoglobulin to the pathology only and not to the healthy tissue. And that's the reason loading inside platelets nanoparticle may be the idea. Again, you can also give stem cell therapy, RAS, responsible for the modulate the immune system, or exosomes. Exosomes has all the ingredients that helps to modulate and have the Th17 that balance the immune system. And it does help to decrease the autoimmune reactions. So you can go to Dr. AJ and get from him the exosomes that you're looking for. So again, this chronic inflammatory immune response do overlap and trigger with the autoimmune diseases, and can manifest as an autoimmune disease. So autoimmune reactions are when the immune system is mistakenly attacking your own body tissue. That's what we call autoimmune. And it causes inflammation and damage that occur in chronic inflammatory immune response. Autoimmune reaction when the immune system, and I think how we manage that, again, try to find out which part of the immune system is hyper-inflamed. Is it Th17? Then just give the medication that suppress the Th17. Don't give a medication that suppress the whole thing, including Th1 and cytotoxic T cells. When you suppress it, like cortisones, then you put the patient at risk of having cancer. But they say, no, I'm going to give ivermectin, I'm going to go hydroxychloroquine, methylene blue, I'm going to give thymosin alpha. That is specifically does inhibit the Th17, because most of the time, those chronic inflammatory immune response, they are Th17 hyperinflammation. You may see some Th2 hyperinflammations, and that gives you some, what we call the conditions called histamine syndrome. Then mast cell activation syndrome. Then you want to say, I'm going to give something that will inhibit the histamines production and Th2. So yeah, I mean, basically, you based on your cytokine profile and lymphocyte mapping, you can definitely direct the right agents or give the right agent that inhibit what's being overactive among those three sort of inflammation: Th17, Th2, and Th1. But most of the time, you will find that all of them are overactive of Th17. So the immune modulation agents, better than immune suppression, can regulate the immune system and prevent or reduce self-attack. Again, you can also give regenerative therapies. Those are the 4 pillars that involve using growth factors, peptides, platelets-rich plasma, platelets nanoparticle. Platelet nanoparticle, by the way, they act like detox as well. They act like cargoes, and they can pick up all the myotoxins and spike protein. So if you take those platelet nanoparticles and you load them with methylene blue and you load them with peptides, I think that's the best option. And then the platelets itself, nanoparticle, will act like a detox. So giving all of this, giving exosomes will be good too, because they are immune modulators. Growth factors, peptides especially, I think that would be good, especially oxytocin. If the peptides are prohibited or banned by the FDA, oxytocin can be the one that you can use intranasal, or you can use 2 international unit injecting around the umbilical. I think that what Dr. Joseph is doing, and he has good results from a dog who is having rheumatoid arthritis, severe rheumatoid, crippling dog because of the aging, and he's injecting oxytocin to that dog, and it seems like the dog is going walking, and I mean, it's their movement and mobility is better. So oxytocin does have effect, especially if you inject it internationally in 2 international units.
And to make it less confusing, 2 international units equals 20 units on in a BD syringe, insulin syringe. So yeah, so 2 international units when it's 10. Forget, yeah, because it's usually I get confused sometimes myself when I try to, but I have worked out the math. It's equal to 20 units in a BD insulin syringe.
Is it a sub-Q thing?
The subacute, yes.
Yeah, so when I went with Dr. Joseph last time, we went last time for Vegas, right? So I enter his room and I can see all the insulin syringes laying down the table. And if somebody from outside who doesn't know him, say, "Well, this guy's real hardcore drugs, man."
A problem with something.
Yeah. So anyway, so he's injecting himself with oxytocin. I think oxytocin can be a good replacement of peptides in case of peptides being banned all over. I mean, you can use oxytocin. Growth factors, all of this may help in reducing the inflammation and healing and induce regeneration and optimizing the health of the patient. Of course, those peptides and oxytocin will accelerate the healing and regeneration process, improve the function and appearance of the affected tissue and organs. I like to give also anti-fibrotic drugs like low dose losartan as an anti-aging dose. That will be something that we can take. Again, the weight loss capsule contain already metformin, so we consider them anti-aging drugs. Therefore, they should used within caution under the supervision of qualified doctor, of course, making sure that all of the medications is being recommended by an MD or DO or somebody who has a training to prescribe those. So the immune system play a crucial role, and I think that's the reason, Dr. Joseph, you say immune system needs to be regulated, needs to be checked deeply by lymphocyte management, cytokine profile, especially when it comes into a case like chronic inflammatory immune response or chronic inflammatory syndrome. As it is, they're responsible for both initiating and maintaining the inflammatory responses. And so it's very clear, and if you see, Dr. Joseph is talking about the CD4 and all those lymphocyte mapping and how you can restore their balance, and you need to visualize them first. You cannot just shoot in the dark and say, hey, I'm balancing the immune system, and he did not do even lymphocyte mapping cytokine. In order to know what you're doing and also monetize the efficacy of the treatment, having a shot of lymphocyte mapping and then do all the treatment after 6 months, you do another lymphocyte mapping and cytokine profile and see what you have impacted or have done into those diagnostic testing. Is there an improvement or not? And so
that's perfect. Just to see that right there is perfect, because again, we just have to drill it in our heads. I believe this to be true from my experience, is we need to restore the immune system while we're modulating it at the same time. We've got to get that CD4 count up. More people have low CD4 counts than you think. Almost every lymphocyte map I saw was either low or suboptimal in their lymphocytes in general. And I saw a CD4 count of like 250. I mean, that's creepy. But you have to think in terms of, well, what do we do? Well, I mean, if we get the hardcore steroids, like you said, we're going to suppress the immune system even more. That's why Amlexinox is the first choice, because that modulates the immune system without the side effects of a steroid and suppressing the immune system. Now, dimethyl fumarate can have an effect can cause a slight lymphopenia, but not as bad as a steroid. So, if you need to stack those on top of each other while doing, say, thymolin, or it would be a combination of thymosin alpha and thymosin beta, that's the way that's exactly how to think about it. We need to restore the immune system and modulate it at the same time. Then we got to see, well, what pathogens are active, because they're all releasing their biotoxins, but at least we know that some of those will go into remission. And then we've got to clear out the biotoxins, because there's a good chance that if you're suffering from this, you're one of those people who cannot detoxify or clear, say, the mycotoxins from your system. So you have to have some thinking towards, how do I get rid of these biotoxins?
Right. So we need to balance the immune system instead of suppressing it. And you need to do lymphocyte mapping to see which one is hyperactive. Is it Th17 hyperactive, Th1 is hyperactive, Th2 is hyperactive? Those are inflammatory or effectors, right? Those we consider pro-inflammatory cells. And if they're overactive, they cause all this damages, including Th2. Although this AI is a little bit behind the curve, where he thinks that Th2, it's anti-inflammatory. It's Th2 is an effector T cells, and allergy is inflammatory mediated by overactive Th2, right? And so this book, this II needs to be, I edit it. I need to go through editing the book again and making sure that they are being upgraded to understand Th2, Th17, and Th1. Those are effector T cells. If they are overactive, they can cause inflammation. If you have overactive Th2, you will have allergies. If you have overactive Th1, then you have this cell-mediated damage of the tissue. And if you have overactive of Th2, Th17, then you have this neutrophilic vasculitis and neutrophilic damage and interleukin-6 mediated inflammation. And so if there's overactive of Th17 or Th1, you need to go ahead and give drugs that helps to suppress them. But most of the time, chronic inflammatory immune response, they will have overactive Th17. So that I want you to put in your count. And if you suppress the Th17, you can manage those conditions. So focus on Th17 hyperinflammations. And yeah, if you see too much of Th1, then you may give something that helps to shift the Th1 to Th2, which is like thymosin beta. But if you see, there's too much of hyperactive Th2 and Th17, then you need to give something that inhibits the Th17 and push the immune system to Th1. And so that's how we do the shifting thing, inhibiting Th17 and shift the Th2 to Th1, like thymosin alpha will do that. Naltrexone inhibit the Th17, Methylene blue inhibit Th17, ivermectin inhibit Th17, name it. Laxanox inhibit Th17. So all those drugs will be part of the measurement of chronic inflammatory immune response. And as I said, as Dr. Joseph said, you need to stack them, go with the low potent to the high potent, because most of the time the high potents may have some side effects. So let's go with step-by-step wise and add as we go. And if the patient is stabilized, health, and his immune system is being balanced, then you don't need the harsh steroids or anything that suppress the whole thing. But sometimes you may need it. You may need to give them hydrocortisone to reset the immune system, and suppress it in general, and then continue replace it and continue with polyphenols and things that we are talking about.
Okay, I got a question. I got a question real fast. With the immune testing and modulation and all the specificity that we're talking about right here, does that kind of fly in the face of what conventional medicine is doing by giving all of these harsh immunosuppressant drugs, all these brand new damn drugs?
Right. Yeah. Well, the thinking is off, because first of all, they're giving an immune suppressant that has lots of side effects, and the other problem is they are not even thinking about what chronic infections are involved, because
or cancer,
look,
or
yeah, exactly. AIDS patients, they don't die of HIV, they die of opportunistic and infections and cancer. It's the same process. COVID is HIV in disguise.
And all they do is say, well, if you've had TB, don't use this drug. Well, anything that's going to suppress the immune system and put it almost down to zero, you're just opening yourself up for a whole host of infections. And imagine what the mold toxins can do in someone who has mold.
Right. So that's the problem with when mainstream medicine, when they start giving high cortisones. I mean, you can use the cortisones for the short term.
Well, I'm thinking about like these things like, what is it, like Skyrizi and all of these things.
And they use those cytokines modulators. Yes.
Yeah, right.
The problem with those modulators of cytokines, which are antibodies, right? They when you give it nakedly, it goes everywhere. It will help the pathology, yes, and suppressing that immune at the site of the pathology, but it will also suppress the immune at the site of the healthy tissue, which make the healthy tissue sick. Like if those antibodies that we are giving, like anti-CTLA, anti-CTL4, anti-PD-L1, those are used for cancer, right? To enhance the immune system and mobilize the Tregs into Th1 and cytotoxic T cells. But if you give it nakedly, it goes everywhere, then you may trigger colitis and hepatitis. Yes, you're trying to strengthen the immune system and cytotoxic T cells of the cancer and remove the Tregs. That's right, with those strong antibodies. But at the same time, you may initiate inflammation in the healthy tissue, and that would drain the immune system. And that draining the immune system will lead to cancer to grow, because you're draining the immune system instead of killing the cancer. You're destroying your healthy tissue, or you're giving immune suppressions like cortisones and methotrexate and all these things, that harsh ones, in a long period of time, and you suppress the whole immune system, especially cytotoxic T cells and Th1, because that's what does steroids. They suppress the whole thing regardless, right? That will lead to put the patient at risk of infection or cancer. So what we do in lymphocyte mapping and cytokine profile, we are targeting only the one that's been hyperinflamed. Let's say if we have too much of Th17, let's only give something that have the Th17 without touching the Th1 or touching Th2. Okay, we have too much of Th17 and Th2. Let's give something that have the Th2, like Benadryl or antihistamine, and something that have the Th17, like ivermectin or like methylene blue or hydroxychloroquine. Or if you want to give antibodies that modulate the cytokines, you need to load them inside platelets nanoparticles, and making sure those drugs are being taken to the pathology versus going everywhere. And that's the chronic disease prevention and management, is targeting therapy. It is personalized, it is selective, and it's trying to only modulate what's being hyperactive without suppressing the immune system where we need it to combat the infection or cancer. You got my
And in
point?
addition to that, just to refresh our memory about amlexinox, amlexinox is great because it's a small molecule. Okay, that's almost like its own category. They behave like peptides in that they modulate versus, kill or shut something off completely. But it's modulating master regulators of inflammation. So you're working at the level of tank binding kinase and NF kappa B, even the phosphodiesterase pathways, which are you are modulating from a higher level, while at the same time you're also modulating many of the enzymes pathways involved with cancer formation at the
Right.
same time,
So very
based on
important that you don't touch the
many of
cytotoxic T
the
cell.
reviewed.
Right. Very important that when you start to modulate the immune system, you don't suppress the Th1 and cytotoxic T cells. That's the problem with all those harsh chemicals, immunosuppressors. Once you start suppressing Th1 and cytotoxic T cells, you put the patient at risk of infection and cancer, especially in the intracellular pathogens.
So
And
can we say that these drugs are actually either making people worse right now, or downstream they will be worse?
if they use it for a long period of time, it will suppress the cytotoxic T cells and put the patient at risk of cancer, including those cortisones and methotrexate and all those harsh chemicals that the big pharma. It's good for short term of period of time, short term acute conditions. Mainstream medicine did very good in acute conditions, but in chronic,
Yeah.
replace that with amloxanox, with low carb diet, with all this integrative approach that we're talking about. So even if you use those harsh chemical, you use lesser doses than the one that the big pharma are using.
Right.
So that's
Right.
a smart tactic where you don't want to touch and suppress the Th17, the Th1 and cytotoxic T cells. That is no.
I think this, sorry to interrupt you, but I think this is our big fight right here, is that the conventional people are so, I guess, set on using acute treatments in a chronic fashion, and that's when things get worse.
Right. And that's where we. Right.
That's 100% right, because first of all, like Dr. Halasa said, has said all along, they're not learning redox medicine, so they're not savvy with tank binding kinase, N kappa B, phosphodiesterase pathways, IKK, all that stuff, which I know it's confusing, but I've been through it. I've been able to make sense of it and organize my thoughts. But we have to make distinctions between acute scenarios and subacute and longer term periods. And we have to realize and organize in our thoughts, like, yes, amlexinox is mild to moderate, but that's a long-term one. We haven't found any side effects with that.
Right.
It's very much like a peptide. That's not going to hurt anything, and it's going to have the anti-cancer effects. Whereas the mainstream docs, I hate to keep putting them down, because I used to be mainstream. I just think they just don't know this stuff, and they only have the tools that they have.
Right. I almost envision this as a specialty, I think, and that's what Dr. Halasa is getting at, that it would be really nice if people have an acute condition to get treated acutely, and then have the acute care provider refer the patient to someone of our ilk.
Right. And that's the whole about this program, is to tell those doctors, hey, in chronic diseases, you need to tackle it by multi-pharmacy, by multiple approach. You need to look at the redox, immune, regenerative, metabolic, and fix all of this, so that you don't need to use that high dose of steroids and high dose of immunoglobulins, that those cytokine modulators, which may cause all this side effects. You may need less dose, and maybe none, if you're able to manage the patient's inflammation with all those integrative approach that we talked about. I never say none to the big pharma products, but can we use it wisely with the lower dose and and do all those things that helps to tackle the inflammation, the redox, and the regenerative status, and that will be more friendly to the biological process of the body, because all those harsh chemicals can compromise the mitochondria and
and then for ourselves, sorry to jump in like this,
No,
for ourselves, I think we have to organize our thoughts too about where is the patient at. Are we dealing with, subacute, which is, sort of acute? Like when you're as sick as I was almost defeated. That's when the recommendations, the thinking of what do you do first, what's most important? Because if you start saying, yeah, blueberries and meditation and yoga, you're completely missing the point.
exactly.
We have to know where is the patient at, what's most critical. This person has AIDS. They're having opportunistic infections. They're being invaded. They're releasing toxins which are shutting down their mitochondria and their other cellular products. The dog is getting into it now. This is the one that takes the oxytocin. But you see what I mean, and you'll hear me get frustrated a lot of times.
I totally agree with what you're saying. I think my point is that if it's an acute situation, needs to be treated acutely. After that, there are, like we're talking about chronic disease management. I don't think we're arguing, and I'm afraid that the mainstream people may think that all of the things that come out on these new treatments and microbiome and all of this kind of stuff, I think that they are getting defensive about this and think that it's an argument, whereas I think it should be it's like a team trying to help someone. And just as you said, Dr. Joseph, we need to know exactly where they are. I mean, that's like they say, you got a compound fracture of your leg, you don't go to the chiropractor. No one wants that. Everybody wants the patient treated as they need it.
Exactly. And I'm suggesting even amongst ourselves, we have to organize our thoughts about where do we start? Is this person somebody that is under attack and they're kind of more like an acute, we'll say subacute, and that's where going straight for the immune system. What are the pathogens? This person's being invaded. This is a dire situation. That's the first thing. And then when we get that under control, then we can work them into increasing their exercise and all of the different strategies.
Yeah,
but we have
maintenance therapies.
The maintenance therapies, but we have to know where to start and what's most important. And I think it's becoming more clear through this lecture, what that looks like.
Right. So where we are right now. Yes. So basically, if you see that all those chronic, those autoimmune diseases, multiple sclerosis, inflammatory bowel disease, systemic lupus, the common denominator here is that they have hyperinflammation of the Th17. So anything that inhibits the Th17 will help all those three conditions. Now, some of them, they may have Th17 and Th1, like multiple sclerosis. Some of them, they may have Th2 and Th17, like ulcerative colitis. Crohn's disease, they may have overactive Th1, Th17, but the common denominator is Th17, hyperactive. Now, you will see some of autoimmune have Th1 overactive, some of them they have Th2 overactive. So you really need to know which one is Th1, Th2 dominant. And then if you want to manage it, inhibit the Th17, that's first thing you do. And then if it's Th2 dominant, then you start shifting it to Th1 using, for example, interferon gamma. Or if they are Th1 dominant and it's Th1 dominant, then you want to shift the Th1 to Th2 by giving thymosin beta, for example. So those immune conditions are characterized by excessive production of pro-inflammatory cytokines. As I said, could be Th1, Th17, or Th2. This AI is a little bit behind the curve. He thinks everything is Th1. Now, there's also some autoimmune disease where you have hyperactive Th2, Th17, and this is the case of COVID, for example. In post-COVID, you will see the whole immune system is shifted to Th17 and Th2, right? And that is the problem, because if you shift the immune system to this directions and you compromise the Th1 and cytotoxic T cells, then you put the patient at cancer. That's the reason the patient with COVID or post-COVID, they have high risk of having cancer. Or a patient with infection of Lyme disease or fungus, they polarize the immune system Th17, right? And some of them into Th2. And that's the problem, because you drain the immune system away from cytotoxic T cells and Th1, and you're putting the patient at risk. So can we say confidently that chronic inflammatory syndrome, chronic inflammatory response syndrome, is a risk factor or a disease that would put the patient at risk of having cancers? And if we manage this chronic inflammatory, we reduce the chance of having cancer. We know the cancer chance that you're going to have during your lifespan is 50%, is the 50 flip of the coin. And so if we start managing all these conditions, we definitely can help to decrease that chance of 50% having cancer. And so, again, these autoimmune conditions are characterized by excessive production of pro-inflammatory cytokines, Th1, Th17, or it could be Th2. Study using marine model of multiple sclerosis. We know multiple sclerosis, it's Th17, Th1, hyperinflammation. And so if you want to manage, you cannot just say, I'm going to inhibit the Th1, right? I'm going to give interferon gamma antibody that inhibit the interferons, and I'm done. No, it's not enough, because they did it, they tried. And what happened is that it did not solve the problem, because they thought in the beginning that multiple sclerosis is Th1 dominant, and just suppress the Th1 dominant cytokines, like giving antibodies against interferon gamma, and you can treat the condition. They find out this is not the case, because this condition also they have Th17 hyperinflammation. So you need to inhibit the cytokines of Th17 as well. And you cannot say I'm going to give them inhibit the Th1 cytokines by giving antibodies that blocks them without blocking the Th17. They try, they fail. And from there, we understand that multiple sclerosis is it's immune disease where you have both Th1 and Th17 hyperactive, and you need to inhibit both of them in order to manage this disease. And so this chronic inflammatory immune response is causing this imbalance. It's causing this overactive of Th17. That's the dominant. That's the main thing. And either Th1 or Th2. And if that's the case, you really need to balance it, suppress it, and balance the immune system in the way that you pick which is overactive, and you work on the drugs that suppress those overactive, or you try to shift the immune system from Th1 to Tregs, like using thymosin beta, or to Th2. So this Th2 and Tregs are considered anti-inflammatory. This is an old AI. Th2 is not an anti-inflammatory. Why? Because allergies is mediated by Th2 cytokines, interleukin-4, and so the Tregs, yes, are considered anti-inflammatory for sure. But here's the thing: if a patient has inflammation that is overactive Th1, and you said in order to manage it, I shifted from Th1 to Th2, yes, then giving anything like interleukin-4 in those cases, it does help to manage those patients. And shifting it from Th1 to Th2, it's a management, and that way you can consider Th2 as anti-inflammatory. But in general, I think it's better if we just said that the Tregs is absolute anti-inflammatory cytokines, which we know the inflammatory cytokines, or in other words, the cytokines of Tregs, right? It's interleukin-10. We know interleukin-10 does suppress all the effectors, whether it's Th1 or Th2 or Th17. And so we need to restore the balance. If you have too much of Th17, you need to inhibit it. If you have Th1 overactive, you need to suppress it, or inhibit it, or modulate it, or shift it to Th2, and vice versa. If you have Th2 overactive, you need to shift to Th1. And as I said, all those chronic inflammatory response syndrome do have overactive Th17. However, reducing the level of Th2 and Treg cytokines can impair the immune response. Oops. Okay. Yeah. Here's the thing. If you reduce the level of Th2 and Treg cytokines, can impair the immune response to biotoxins and decrease the risk of infection inflammation. This is very important. You know, uh, uh, you need to make sure that when you balance the immune system, you balance it to the point that you don't compromise the immune reactions and against the pathogens. So that's where the smart thing that you do when you're managing those autoimmunes diseases or the chronic inflammatory immune response. And so you need to have immune system that fights those bugs. At the same time, you need to modulate the immune system where you don't have this hyperinflammation. And that's the trick where you're going to move from here. If you have Lyme disease, and the Lyme disease, let's say they have too much of Th17 and Th1 is overactive, then you say, okay, well, let me have the Th17 and move a little bit to Th2, right? By giving interferon, by giving thymosin beta here in this case, right? But you don't want to, if you do too much of shifting here, then you may compromise the Th1. And sometimes, like Dr. Williams said, I'm doing the cycling. I'm shifting the Th2, Th1 to Th2, and then Th2 to Th1. So I'm doing cycling of interferon alpha, interferon beta, and that cycling things will help to decrease inflammation at one stage, and then increase the inflammation to kill those cells that's being infected with the bugs. So there is a lot of training and tricks on how to modulate the immune system to, from one side, you want to decrease the inflammation that damage the body. On the other side, you want to enhance and boost the immune system to kill those bugs or neutralize those bugs, and also to kill those cells that's being infected with those bugs. So chronic inflammatory response syndrome patient had reduced the level of Th2 and Tregs, cytokines such as interleukin 4 and 10. And that's the case, you want to really move the whole immune system to Treg and to Th2, as I said, by using thymosin beta and also inhibiting the Th17, because all of them, they will have hyper Th17 and interleukin 6. And so that's the art of immune modulations. And you can learn it by doing those cytokine mapping and thymosin mapping or lymphocyte mapping and cytokine profile. And me and Dr. Joseph can help you to interpret those results and then help you to plan. Let's say if you have low B cells, oh, well, that could be because of Epstein-Barr virus. So let's give methylene blue and put the patient in bed and give ozone so we can kill that bug, so that B cells will go up. And then if the B cells is low, let's also give some thymosin beta here, you know, okay. Oh, you consider, let's kill those infected cells of those B cells by moving the immune system to cytotoxic T cells, so we can get rid from those B cells that's being infected, right? And then once you destroy them, those B cells that's being infected with the Epstein-Barr virus, by mobilizing the immune system to Th1 cytotoxic T cells, but that mobilization can cause too much of inflammation that damages the tissue. So let's go ahead and give cycling that will move the Th1 back to Th2 by giving thymosin beta. So, you know, this moving from, sometimes we do the shifting cycle,
I
moving
can
to
add
Th1
something.
and back to Th2.
I can add something new. Is the more I'm learning about thymolin, is that you kind of have the best of both worlds. It boosts Th1 and Th2 while at the same time it's modulating inflammation at the same time. So I think that might be a happy medium between extremes. If you want a safe place to start, at least where I'm at with my understanding, is that thymolin is a safe place to start. It's not going to overdo anything, but it will boost or restore the immune system while modulating inflammation at the same time.
Yeah, so thymolin is coming from thymosin alpha, right? And thymosin alpha will be better than thymolin, but they stimulate the immune, whether the Th1 or Th2, as you said, but they are more favorable into Th1 and cytotoxic T cells. So they increase the whole lymphocytes, but they are more favorable to Th1 and cytotoxic T cells. So when you get this, you're increasing the immune system in general, which is good. You're moving it to cytotoxic T cells, And what they does, the cytotoxic T cells will kill those infected cells with the bugs, right? But at the same time, thymosin alpha does inhibit the Th17, which is the bad guy. That is too much of inflammation, neutrophilic, which does not do much in those bugs, especially endogenous bacteria. What neutrophil can do with endogenous bacteria? Nothing. You really need to have cytotoxic T cells attaching those infected cells, releasing into perforins, and blow up those cells and inhibit the Th17, right? But
Oh, that's assuming that we have access to thymosin alpha and thymosin beta. Because I like that idea too. We talked about it. You do thymosin alpha for
yeah.
4 weeks, and then you do thymosin beta for 4 weeks. So you
Right.
alternate.
Right. So
But thymolin is accessible.
right. Thymolin is a piece of thymosin alpha, and it works as similar to thymosin alpha. They boost both sides, but they favor Th1 and cytotoxic T cells, which that's what you need in the beginning. You want to get rid from those cells that's being infected with Lyme disease, right? But after you get rid from it and you release those bugs from those infected cells, then you have all this hyperinflammation that may generate. Then you may need to cycle and give thymosin beta to push the Th1
Well,
back to.
that's provided you have access to thymosin beta. The only place that has it is
Well, you can
prime,
use the
is prime peptides, which is not for human and animal use. I don't have a problem using it, but
BBC
I have
157 will be alternative to thymosin beta.
what's that?
The BBC 157.
Oh, BBC one is I don't see that as its mechanism. BBC 157, the mechanism has to do with activating the genes for vascular endothelial growth factor
No,
in the
it does.
context of healing, and it's anti-inflammatory, but in the
Yeah, it does help,
context of
Greg.
the immune system, I don't recall it restoring or the B cells.
Yeah, it does help to move things into Treg and Th2.
It does. Okay.
Yes, and it inhibit the Th17. So when you do thymolin, if you don't have the thymosin beta, you can use the BBC 157. That will be an alternative to thymosin beta. But anyway, it's an art. Okay. And you really, me and Dr. Joseph, I think, Dr. Patel, are most people are being mastering this, and so we can help you all the way to figure out all those tricks and how to modulate and move the immune system back and forth to make sure you get rid, especially Lyme disease. One of the difficult. I mean, that's one of the questions that Dr. Patel. We have like 1 hour talk about how we tackle and modulate the immune system. So the immune modulation potential strategy for preventing and treating chronic inflammatory immune responses. So this is very important. This is the topic where chronic disease prevention management is mastering it, and it's showing the importance of the immune modulations. Those are unmet medical need. This is the education that you need to start training yourself, because this is the only way you can manage those chronic disease, is to know exactly your lymphocyte mapping and your cytokine profile and how you can modulate it, how you can balance it with those tools that we have available through those compounding pharmacy that we're working with, and with the protocols that we can recommend you can definitely do better in managing chronic inflammation, especially chronic inflammatory immune response. So some natural synthetic agents such as herbs and botanics, those polyphenols, low dose naltrexone, thymosin alpha and beta, and things that immune modulator effects, naltrexones, amnoxanox, all those definitely help in modulating the immune system, and balancing it in a way that you suppress what's being hyperinflamed only, without suppressing the other pieces of the immune system, especially the cytotoxic T cells and CD8. You don't want to suppress those two effectors, because once you do that, you put the patient at risk of intracellular infections and also of cancer. So curcumin will be a good way to inhibit the Th17 and balance the immune system. Polyphenols in general, low dose naltrexone. We know those polyphenols do inhibit the Th17, and they don't suppress the Th1. The inflammation or hyperinflammation of Th1 back to normal. So I think it's called immune modulation. And yes, they enhance Th2 and Tregs. especially when you have autoimmune disease. So you can use those polyphenols in rheumatoid arthritis. You can use amloxanox. We talked about the mechanism, oxytocin, thymosin, all these peptides we talked about. Curcumin can inhibit the expression of inflammatory genes, from redox, because we know the redox, if it's overactive, the pro-oxidants, then it will aggravate the whole inflammatory cytokines of three of them, the Th17, Th1, and Th2. And so giving that thing that helps to suppress the inflammatory or the pro-inflammatory enzymes and epigenetics, and stimulate the epigenetics of the antioxidants, would definitely put the fire down and put those inflammatory cytokines down. Another example is low-dose naltrexone, which we know it does inhibit the Th17. Yes, and where we are right
And,
here.
and I was going to mention one thing, and my mom had mentioned it, and it makes sense. As much as we are not wanting to suppress the immune system more with steroids, there is something to be said when somebody if somebody shows up to the office and they are just subacute, like we said before, they are just so down, they're so exhausted, they're so inflamed. To give them a good shot of Kenalog just to start may not be a bad idea, because how did you describe it?
Well, you have to persuade them they can feel better. And
Right.
and you can't fight a war without a warrior.
Right.
You have to give them some fight. And that sometimes does help.
Yeah, just right at the beginning, and then to get them back partially on their feet, or to believe that they can actually fight back and feel good for once, and then start stacking some of these thymus at the same time. They have to be ordered. Like I'd give them the shot right there in the office, like boom, just so that they can just in 2 days they'll like, oh my goodness, they're ready to fight, while the other stuff is being ordered, and the thymosin alpha and the thymolin, or the thymosin beta, the BPC 157, and the lymphocyte map is ordered, and the pathogen map is being ordered, whatever you want to call it. That's another protocol I think we could even put as a protocol.
Right. It's very important. If the patient has hyperinflammation of Th1, Th17, even Th1, Th2, all of them is hyperactive. And in that case, you really need to suppress the whole immune system and reset the immune system. You go ahead and give them a shot of cortisone. I have no problem with that, as long as it's an acute. But then you follow it with all the things that we talked about, because you don't give cortisone for a long period of time, because it does suppress T cells and put the patient at risk of bacteria infection, especially the intracellular pathogens and cancer. As long as you're doing it in acute, and then you follow it with polyphenols and thiols and low dose naltrexone and those immune modulators, then that's the best thing to do. Like, it's like a cancer. If you have a big mass of cancer, you don't want to say, I'm going to do chemo radio. Just go ahead and get that big mass out, debulk it, and then work on those little tumors by using low dose chemotherapy and immunotherapy and all that stuff. But if the cancers can be resected, that bulk, just go ahead and get rid of it and remove it surgically, and go ahead and follow it with treatment that helps you get rid from those small spots of tumors. So this exact same thing can be applied in any chronic condition. So I'm not against the mainstream medicine giving cortisone to reset the immune system and give that kind of blow that helps and put the patient, reset the immune system. So this chronic inflammatory, as I said, response syndrome, the CIRS, stands for chronic inflammatory response syndrome, and it's a condition that occurs when the body immune system is constantly activated by exposure to various environmental toxins, which we need to remove it first, and then we need to put the inflammation down. Yes, you need maybe cortisone to put it to reset, and then you continue or follow it with polyphenols and things that we talked about, the immune, the metabolic redox, and regenerative therapies. These toxins can trigger inflammatory response, induce hormonal change in the body. Yes, if you have imbalance in the sex hormones, all of this needs to be regulated. This can lead to persistent inflammation, oxidative stress, which are harmful processes that can damage various organ and tissue. That's true. and it can lead to fatigue, cognitive impairment, mood disorder, right? And then patient will be having difficulty to be diagnosed for because of that. Everybody will say, "Oh, she has Alzheimer's, she has fibromyalgia," and basically it's chronic inflammatory immune response. And they are
Yeah.
giving all the treatment that just masks the problem and not to the root cause of the problem. And all the specialists will be failing dramatically because they don't know that there is other big conditions that they look like Alzheimer's, but they part of it. And the pathogenesis here, it's just more of Lyme disease or spike protein or mold, and they're treating it as Alzheimer with the traditional protocols, or treating fibromyalgia and giving them treatment of fibromyalgia with all this antidepressant, which will put the patient and become crazy, and instead of going into right, and eliminate the root cause, could be the mold. The patient is back normal. I mean, I have doctors who give up from the way that the traditional, she has mold infection, and she been treating herself with all the antidepressant, and she got so crazy, and then she gave up on the main medicine. And I know Dr. Yusuf, he knows this doctor, and she start just focusing on mold, and that's it. Her treatment and management is all based on mold, and everything is caused by mold, and that's true. It could be. I'm not against that. Mold could be a big factor in aggravating any existing chronic disease. It needs to be considered in managing those disease in the equations. So chronic inflammatory response can increase the risk
Yeah,
of.
Dr. Halasa, I think
Right.
probably about time we land the plane a little bit. I think this was an excellent lecture. I think we're
I
getting
think
close to the end.
how many people left here?
Yeah, yeah. It's just the three of us.
Oh, there's 14 here. Yeah.
Yeah,
We
15.
20 to 40. That's good. 20 to 40. We drop 6 for 2 hours lecturing. That's not bad, right?
That's not bad.
No.
I'm just trying to, I mean,
Yeah. So
I know we
anyway,
could,
what
I know
I
we could
want to
probably
add
go for another 2 hours. What's
yeah,
that?
let me add something last one finally, okay? Is that this chronic inflammatory immune response suppress it will polarize the immune system away from cytotoxic T cells and Th1, and will put the patient at risk of cancer, right? Because you're pushing your immune system away from cytotoxic T cells. You have hyperinflamed Th17, hyperinflamed possibly Th2 like COVID, spike protein, and this put the patient at risk of cancer. So patient with mold infection, patient with COVID, patient with Lyme, all of those people, they may have high risk of developing cancer because their immune system is imbalanced and is being polarized away from cytotoxic T cells. And what I need to do is that when you're trying to treat those patients with any injectable drugs out there, we recommend you load it inside the platelets nanoparticles. This will target the treatment to the pathology, whether those treatment is redox therapy, immune therapy, immune modulation therapy, chemotherapy, metabolic therapy, load inside plated nanoparticle, get them into the pathology. That's what we train to do, right? And also those nanoparticles itself will act like a detox. They will act like a cargo, and they start collecting and picking all those mycotoxins, all those biotoxins in the blood. It's like you are cleaning them from the system using those platelets nanoparticles. Again, you can use regenerative therapy, exosomes, stem cells. All of this will help. I think by this, we have the tools, we have the protocols, and we have this new field of medicine. And we hope that everybody here in this room will be contributing in this field of medicine by, inviting more doctors to the table, by finding us investors, by, if you want to donate, we have a crowdfunding of chronic disease prevention management, and I will list it down in the text. Otherwise, anybody has questions?
No, I just want to thank Dr. Quinn for his input, and anybody else that contributed and asked questions. I found it to be a really good. I think we brought it to life, and I hope the things I said help to paint it a little bit more clear. If you haven't experienced it, or maybe you dealt with patients that were confusing, maybe this created more clarity. But the picture gets more clear the more that we do this, and there is a path. that can be followed. I can see where you kind of know where to start, and it's less guesswork. Try this, try that, an order of importance that leads to the other supplements and exercise and dietary and yoga
Yeah.
and sound therapy. Which I believe in it all, but you gotta know where to start.
Right.
Yeah,
Oh.
it's like, as I always tell people, there's no such thing as a magic bullet. It's more or less a magic shotgun. Got to do a lot of things.
Yeah. Yeah, and sometimes you got to get aggressive. I mean, and you got to believe these patients. They're not crazy. They're becoming crazy because they're sick.
Yeah, yeah. Well, it would drive anyone crazy.
Right.
Yeah.
Okay, well, we'll see you next week. We're gonna be in AJ conference, right? Dr. Joseph James, looking
right.
forward to meet you there in person. I don't know if Dr. Quinn wants to come, but a lot of doctors here, they're gonna be there possibly. And again, I put my GoFund website. Please share it with all people that you know so they can contribute financially funding this platform of education. And invite as much as you can from doctors. I need all of you to be part of it, and all of you will be the main people and main docs who are advancing medicine and adding more to the table. Is that good?
Have fun. It's
Okay.
wish I was gonna be there. Hey, tomorrow Dustin Sulak is gonna be doing ketamine at home tomorrow with Dr. Clearfield's group.
Okay, we're
gonna be
Dr.
interesting.
Yes, sure. Tomorrow we'll be there.
Excellent. Looking forward to that.
All right. Well, good night, everybody. Take care.
Good night. Thank you, everybody.
Yeah.
All right.
Bye-bye.
Bye-bye.